Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha. I am a nurse here at UWorld, and this week we have another heavy-hitting topic up on dock for us, and that is going to be heart failure. So heart failure is an incredibly important and challenging topic, not only to be successful on the NCLEX, but you're going to see this sprinkled throughout your nursing school curriculum classes, in med-surg, in fundamentals, and you're definitely going to see this when you get into practice. So we want to make sure you guys are successful in all of those areas, and that is why we are covering it in depth today. A couple of housekeeping things before we get started. We do take into account the topics and the different body systems that you all want to see us present. So keep letting us know in the chats what topics, what body systems, what questions you guys have, so that way we can cover them in the future and make sure we are tailoring our content towards what you all want to see. There will be questions sprinkled throughout today's video to check your understanding, as well as NCLEX style questions at the end, so make sure you stay tuned for all of those. If you have not already, give us a follow at UWorld Nursing. That way you don't miss any of our lectures or our live sessions in the future. This live will be on demand when we are done. So if you have to duck out early, maybe you have to kind of come in and out, or maybe you're going to join late, you're always able to find it on demand on any of our social media channels. Personally, I find that YouTube channel as the easiest one to search. So as always, drop your comments, drop your questions into the chat, as well as your answers to today's questions, or simply stop by and just say hi. We always want to hear from you guys. So let's get that chat started by letting us know where everyone is joining from. Who here is an international viewer, who's a viewer from the US, let us know. That way we're always excited to see all the viewers regardless of where you're coming from, but it's cool to see just how far UWorld stretches. So with that being said, let's look at our agenda. We're going to start out with the basics of the blood flow through the heart, because that's going to be a great precursor to understanding both left and right heart failure, which are the types of heart failure we'll be talking about today. Per usual, we'll end the lecture session with some NCLEX style questions. Today we have 4 NCLEX style questions. Normally on these Tuesday time slots, we only have 2. So we have some bonus questions for you all today because you guys deserve it. Again, and we also have lots of little questions peppered throughout just to make sure everyone's staying up to date, understands what we're talking about, and so I can tell what we maybe need to spend more time on and what you guys have down pat. So this is a challenging topic. We're going to work through it slowly, and I'm going to ask lots of questions throughout to make sure everyone is understanding. So let's get started. We're starting out with the basics of blood flow. This is our heart failure 101. We're priming our knowledge here, and we're going to pull up this anatomical image of the heart. So we're talking the basic fundamental principles of heart failure. We're also going to pepper in some pharmacology, but to get our feet underneath us, the best way to do that is to go through blood flow and break it down into the simplest components. So blood flow is a great precursor to understanding heart failure. Pretend that we're blood and we just delivered oxygen to a very important organ and we're on our way back to the heart. So if we're trying to understand heart failure, which means obviously if the heart is failing, something is going wrong, to be able to spot that and understand that, we have to understand what a normal heart looks like and what blood flow looks like through that. So we're that blood, we're a little blood cell. That always reminds me of the Magic School Bus. Maybe that's a little bit older than you guys are, but we just delivered oxygen to a very important organ, and now we're on our way back up to the heart. We're going to make our way through the venous system, or the vena cava, to that right atrium. Then we drop down into the right ventricle, and then we shoot over to the lungs via that pulmonary artery. So remember, arteries take blood away from the heart. I always think A to A is the easiest way to remember this, and veins bring blood back up to the heart. So arteries away, veins back to. The pulmonary artery is what takes blood from the heart to the lungs, because again, it's moving blood away from the heart. So to sum that up, we go right atrium, right ventricle, pulmonary artery. Now we're hanging out in the lungs, getting that good oxygen. We get our oxygen and then travel back through the pulmonary vein to the left atrium, because again, veins carry blood back to the heart. So now we're back in that left atrium, then we get dropped down to the left ventricle, and then we receive a big push out through the aorta to wherever in the body our destination may be. Maybe it's the pancreas, maybe it's the brain, that just depends. So to sum it up, we're going right atrium, right ventricle, pulmonary artery, lungs, pulmonary vein back to the heart, left atrium, left ventricle, aorta, and then the rest of the body. And we're also going to sum up that arteries take blood away from the heart and veins lead us back to the heart. So how does this apply to heart failure? Let's shift gears a little bit. I'm going to start out with a question to challenge you all. Heart failure is the inability of the heart to maintain adequate what? And I'll give you a hint. Our answer is 2 words. So to maintain adequate blank blank. Drop your answers in the chat. Let us know what you guys think the answer is. But again, heart failure is the inability of the heart to maintain adequate blank blank. Let us know what you all think. And I see Becca on TikTok already got it right. Way to go. Cardiac output was the answer I was looking for. Great job, Becca. I see a couple other answers coming through. That was a tricky one, but you guys got us off to a great start. So we know cardiac output is the amount of blood being pumped from the heart to deliver oxygen to the rest of our vital organs. So when we have diminished cardiac output, we have inadequate tissue perfusion. And when we have inadequate tissue perfusion, to put it simply, we have problems. Not only are our organs not going to receive enough oxygen-rich blood, but blood is also getting backed up along the way, causing congestion. And this congestion is going to be in our lungs and throughout our circulatory system. So we're going to start out with the left heart failure before we move on to right heart failure. And keep in mind, heart failure can have a number of different combinations. We can have acute heart failure, chronic heart failure, left, right, diastolic, systolic, compensated, decompensated. But today we are just going to be focusing on left and right heart failure for simplicity's sake. When we say left heart failure, I hope this is no surprise to you all, but we're talking about dysfunction on the left side of the heart. No shocker there, mostly with that left ventricle. Now I'm going to ask you guys another really challenging question. Knowing what we just talked about regarding blood flow through the heart and knowing that it's a free open system of blood flow in the body, if we were to put a plug in that left ventricle so no more blood can come in, where is the first place we're going to see blood start to accumulate or pool? Essentially, where is that blood going to get backed up? So again, we plug that left ventricle, no more room, no more blood gets in. I think the best way and the best hint here is to think backwards in terms of blood flow. Where was the last place that blood was? And that's how we'll know where our backup or congestion lies. I already see a couple of correct answers. Leah on YouTube said lungs. Becca on TikTok again said lungs. I see a couple of great answers. Way to go, you guys. So lungs, yes, left heart failure, lungs. We always think L to L. That's how we are going to remember this. So in left heart failure, blood is backing up into the lungs. Because of this, we're going to see manifestations that mostly have to deal with breathing in our respiratory system because the congestion's in our lungs. So these clients, their manifestations include difficulty breathing, which can look like dyspnea or orthopnea. A lot of these clients are not even going to want to lay flat. They're going to have that trouble breathing at rest or when they're trying to sleep. If you try and lay back some of these clients, a lot of times they're going to get really panicky. They're going to have those bad lung sounds like the crackles and the rails, the sounds that we never really want to auscultate. They can have a cough with that pink frothy sputum, cold and clammy skin because we aren't perfusing that oxygen-rich blood distally, so some of our peripheries may not be getting great perfusion and as a result may be really cold and clammy feeling. Clients will have tachycardia or an increased heart rate because we're trying to compensate for that decreased cardiac output. The heart steps in and beats faster to try and maintain it as a compensatory mechanism. And clients will also see weight gain, and a lot of this has to do with that fluid retention, that congestion. So, main causes of left heart failure. In a nutshell, anything that weakens the heart as a pump, because that's what it is, it's pumping blood throughout our body. Those things are going to cause left heart failure. So this includes things like hypertension, which we know is just high blood pressure. Think about the heart trying to pump against the wind. When you have high blood pressure, the heart has to pump harder to get the same result. It's kind of the same premise as like running into the wind. It takes more effort to get to the same spot. And because of this, our heart gets tired. It poops out, the muscle gets bigger, and our pump essentially gets less effective. Other causes that weaken the heart as a pump include myocardial infarction or MI, left valve problems, and dysrhythmias. Great job, you guys. Way to go. Now we are going to move into right heart failure, but we're going to use a lot of the same principles as we did in left in right. So now in right heart failure, obviously our dysfunction is in the right side of the heart. No surprise there. Again, we're going to work backwards in our blood flow to identify where our manifestations are going to lie, where that backup or congestion of blood is going to be. So we've unplugged that left ventricle as we did in left heart failure. Now we're back to the status quo. But for right heart failure, visualize that we're putting a plug in that right ventricle so no blood can get in. Where are we going to see that blood start to accumulate? So we've plugged that right ventricle. Where is blood going to be knocking on the door, trying to get in, but it can't because there's a plug? Let us know. Drop your answers in the chat. Where is that blood going to get backed up? And again, the best hint here is to work backwards in the flow of blood. So where it's going to get backed up essentially is the last place it was before it tries to get into that right ventricle. Alrighty, I see a mix of answers. So I will go through this in more depth, but someone got it on, it looks like YouTube, the venous system. Yes, you're totally correct. All that blood that's trying to come back up to the heart is just hanging out in our venous circulation. It's just sitting there with no oxygen because, again, veins bring that oxygen poor blood back up to the heart to get reoxygenated in the blood. It's just standing there with no oxygen, not enough oxygen, knocking on the heart's door trying to get in. So the congestion will lie in our venous system, which ties into where we see our manifestation. So a lot of this backup of blood in the venous system causes edema, and this can look like a couple of different things. Clients can experience that peripheral edema, especially in those legs, that dependent edema, that pedal edema. They can have ascites or the distended bellies, those really big, uncomfortable bellies that are just full of fluid. We can also see distended neck vein, and JVD is a really big example of that. I see someone put that in the chat earlier, so you were ahead of the game. Way to go. We can also see the enlargement of the liver and the spleen. So the technical terms for this would be hepatomegaly and splenomegaly. What are the causes of right heart failure? So the typical culprit of right heart failure is, keep your enemies close, it's right next door, it's left heart failure. It will actually infiltrate one side of the heart to the other. Other things that can cause right heart failure include things like lung disease or valve problems can also cause this. So with that being said, how do we manage heart failure? We've talked about all of these really difficult side effects and symptoms. What are we going to do as nurses to help these clients? We want to focus again on the blood flow, and we use medications in this case to treat a couple of things. We have three main objectives. First, we want to use medications to reduce the amount of fluid coming into the heart, which would be our preload, so decreasing the circulated fluid volume. Two is to maximize the function of the heart, so getting the biggest squeeze with each pump or each ejection fraction. And lastly, three is to reduce afterload or just overall blood pressure in the body. So there are lots of different drugs that can help us with this, but we're going to focus on three main drug classes. And those are going to be diuretics, beta blockers, and our ACE inhibitors. Hopefully these are already a little bit familiar to you all. So diuretics, first and foremost, this tackles our first point to decrease that preload and reduce volume in our venous blood, therefore decreasing the amount of circulating fluid volume by excreting it via the kidneys in that genitourinary or GU system. Now there are lots of different classes of diuretics. One of the most common is going to be a furosemide, which the trade name is Lasix, and this is a loop diuretic. One of the most common medications I feel like given in the hospital altogether. Thiazide diuretics, like a hydrochlorothiazide, are also common. We have our osmotic diuretics. An example of this would be dapagliflozin, and our potassium-sparing diuretics, a spironolactone or an aldactone. Now, make sure we're keeping the point that a potassium-sparing diuretic obviously spares potassium, so the risk here is for hyperkalemia or the accumulation of that spared potassium. The rest of those diuretics excrete potassium, so there runs a higher risk of hypokalemia. Just an important thing, something you may see on one of the questions a little bit later. Our second class of medications I want to focus on are our beta blockers, or our LOL medications. They help to lower the heart rate because remember we have that compensatory tachycardia to make up for our decreased cardiac output. Essentially, the beta blockers, they lower the heart rate and they allow the heart to rest a little bit. It's working so hard, it's working too hard. It allows it to take a little rest. It also helps to decrease afterload. Common examples of this, another super common clinical medication is acarbidolol, or a Coreg is the trade name for that. Metoprolol is also a common beta blocker, and labetalol is one that can also be used in an OB or an obstetric setting. Then we have our ACE inhibitors, our last big class of medications. These decrease afterload and systemic vascular resistance. They work to increase renal blood flow. They work to relieve many of those heart failure related symptoms. So common examples of these are our prill medications, captopril, lisinopril, and also important to note, these are not safe to give in an OB setting or to any pregnant client. So with that being said, I do still want to mention some other concurrent medications that clients will most likely still have to be on when they are in heart failure. And some of these are more applicable to like acute heart failure when they're admitted in a clinical setting rather than a maintenance med. So we're going to kind of start out with more of our maintenance meds, and that's an anticoagulant. That's pretty basic, especially if the client has a concurrent AFib or atrial fibrillation. Warfarin, super common example of this. Eliquis is a trade name for a big one, but these are really common medications. Clients sometimes may be required to be on antidysrhythmic drugs, and we also may give morphine. Now again, this is a high alert drug given in more of an acute setting. This is not a maintenance medication, but that morphine helps to vasodilate to reduce pulmonary congestion. So again, because of the high alert drug, it's a risk for respiratory depression. This is only going to be given in a clinical setting with a high level of care, and we need to be frequently assessing O2 sats, lung sounds, respiration count, just so we can make sure this client isn't becoming respiratory depressed. We may give positive inotropes. So these help to increase that cardiac output that we know decreases with heart failure. It helps to increase heart contractility, and it strengthens the heart as a pump altogether. Common examples of this are a dopamine, a dobutamine, and a digoxin, which is probably the most common of those three. So all of these, especially that digoxin, are high alert medications. And the reasons for this is digoxin specifically has a very narrow therapeutic index, meaning the range that we want to be in is pretty hard to hit. We don't want to be too high and be digoxin toxic, and we don't want to be too low and not have a therapeutic effect. So these require a higher level of care, a higher level of monitoring. Again, not a maintenance medication that we're just going to send the client home with some basic pharmacy instructions. This requires a higher level of care. And in that same vein, vasodilators like a nitrate or a nitroglycerin or a nitroprusside, an example of that would be like a NitroPress. These help to do all three things: decrease afterload, preload, and overall blood pressure. So these work to all 3 points that we're trying to achieve, as mentioned earlier. Just like our positive inotropes, these require a higher level of care. A nitro is going to require, a very high level of care. They're not send home maintenance medications that we're just taking every day willy-nilly. These require a higher level of care. Alrighty, so great job, you guys. So in summation, a couple of things to help you remember the key points of what we talked about today. Left heart failure equals backup in the lungs, L to L. That's where our congestion will lie, therefore that's where the manifestations will lie. Cause of left heart failure is anything that weakens the heart as a pump. Hypertension and myocardial infarction, or MI, are super common causes of this. Now in right heart failure, the backup is going to be in the venous system. We're going to get congestion in that venous system, meaning a lot of the manifestations are going to lie in our peripheries, in the edema and the ascites and the JVD. And the cause of right heart failure most commonly is right next door with left heart failure, actually causes our right heart failure. So way to go, you guys. That sums up our lecture material. Now let's move on to our questions. And again, we have 4 questions, which is more than our normal 2, but this is a bit of a shorter lecture, so I wanted to make sure that everyone got their time's worth. So the first question is, the nurse is reviewing new medication prescriptions for a client with chronic heart failure. The nurse should clarify the prescription for furosemide, metoprolol, celecoxib, or lisinopril. Drop those answers in the chat. Let's see what you all are thinking. I see a couple answers already coming in. And we have been dropping this in the chat. I see one that just went out at 12:18, but we have a cardio specific session on 9/22. This is a bit of a different format than we usually use. You actually can use that link to register for it as opposed to these lives that you can just show up on social media. But make sure you check that out. We're going to be covering select all that apply question strategy, and then we're going to be doing a cardio session. Make sure to check it out. There's a link to register. This is again something different that we're doing. You do have to register for this live, but it is 2 hours long as opposed to these 30-minute lives. So if you're interested in more cardio and select all that apply strategy, go ahead and register at that link in the chat. You guys are doing fabulous today. All right, I see 1s, 2s, 3s, and 4s. So lots of different answers. In this case, remember, clarify the prescription means what prescription are we seeing come through on our order set, and we're calling that doctor being like, what on earth are you thinking? This is not right. So option 3 would be our correct option because it's an incorrect prescription that requires clarification. So celecoxib is a COX-2 inhibitor. It is a type of NSAID. We don't give this in heart failure because our kidneys are already strained due to that increased circulating fluid volume. They might not be getting perfused appropriately, and NSAIDs increase our risk of kidney injury, especially if we're giving a concurrent diuretic like a furosemide that was mentioned there. Those kidneys are going to be working hard to diurese that. We don't want to put them strain their function, get an AKI or an acute kidney injury to the point where they're injured, where they're not going to respond to a diuretic and get off some of the circulating fluid volume. So any medication that could damage our kidneys, that's going to strain them more, we want to stay away from, and that includes NSAIDs. So that's why option 3 was our correct option, because it's an incorrect prescription that requires clarification. Call that doctor up and ask them, if they haven't had their coffee that morning. Furosemide, diuretic, we do want to give this. This is a loop diuretic. It does not spare potassium, but we want to help get off that extra fluid. Metoprolol, a beta blocker, something we would definitely give, help to lower that heart rate, give the heart a little bit of a break, decrease the afterload. This is indicated. And lastly, lisinopril, ACE inhibitor, decrease the afterload, help to reduce the blood pressure, something that would be required for heart failure. So again, option 3 was our correct option here. Way to go, you guys. All righty, question number 2. The nurse is caring for assigned clients. The nurse should first assess the client who has COPD with a pulse ox reading of 91% on room air and reports a chronic cough, 2, AFib, an elevated heart rate and reports occasional fluttering feeling in the chest, 3, fibromyalgia, fatigue, and reports generalized pain rated as 7 on a scale of 0 to 10, and lastly, heart failure, edema of the lower extremities, and reports dyspnea. So drop those answers in the chats. Let me know what you all are thinking, and I'll give you a hint. Our correct option is what we talked about today. So that may give you too much of a hint, but there you go. And great job, Lauren on TikTok said acute versus chronic. You nailed the teaching point here. You're absolutely spot on. Way to go. So because I see almost all correct options, I'm going to go ahead and jump into our correct option, even though I gave you a big hint, but that was option 4 is indeed correct. So the rest of the options denote chronic or expected findings, whereas this option number 4 was an unexpected complication. So what's expected versus what's a complication? What is chronic, something that they deal with that we expect to see, versus what means that it's progressing and the client is becoming higher acuity. So option 1, COPD, they typically linger around that 88 to 92 kind of O2 stats. So if we're at 91%, we're not super concerned. That's probably pretty good for them actually. And a chronic cough is going to be expected with COPD. AFib, an elevated heart rate and that fluttering feeling in the chest, again, expected finding for a client in AFib or who has AFib. And lastly, fibromyalgia is a disorder that causes pain throughout the body, having generalized pain that's not localized to one specific area. As a 7 out of 10, again, expected finding. The priority will never be expected findings. It's going to be unexpected findings. It'll never be chronic issues. It'll always be acute issues. The only really acute exacerbation we're seeing here is option 4, the heart failure. We see edema of the lower extremities, and now it's getting to the point where the client is reporting dyspnea. So this client is progressing. This client needs some further intervention. And I see someone says, what is the BP? It does not tell you the BP, but that doesn't necessarily matter in this case because we can use those other symptoms to see that this client is not in a stable mode of the heart failure. They're experiencing worsening heart failure. Alrighty, good job, you guys. Alrighty, question number 3. So the nurse is caring for a client with suspected right-sided heart failure. Which of the following findings would support a diagnosis of right-sided heart failure? Our options are decreased central venous pressure, JVD or jugular venous distension, rapid weight loss, or bradycardia. Drop those answers in the chat. Let us know what you all think. You've done fabulous so far. I hope you're enjoying these questions. We have one more after this. And if you haven't already, make sure you check out our Nurse Life videos. We have been putting out lots of them lately. We just have one with Nurse Rebecca that's almost at 100,000 views. It talks about the at-home NCLEX, or the option to take your NCLEX at home. That should be coming out sometime in 2026. We don't have a certain date, but it gives you a little bit more information about who's eligible for that, how you would do it, how it would work. And again, we don't have, it's not available to the public yet, but always good to stay on top of that, especially for anyone that's planning on graduating and taking their NCLEX in mid to late 2026. Alrighty, great job, you guys. And I see almost all option number 2, which was our correct option, so way to go. Again, right-sided heart failure, we're gonna see that back up in our venous system. That jugular vein is distended. That sounds a lot like venous congestion to me. So option 2 is our correct option. Option 1, 3, and 4 were incorrect. Bradycardia is not gonna be what's happening here. We have that compensatory tachycardia. We're likely not gonna see weight loss. On the opposite side, because of that edema, we're probably gonna see weight gain. Again, these clients can have that fluid retention as ascites in their belly, as peripheral or pedal edema in their legs, or even their arms in that JVD. So more likely to gain weight here. Alrighty, great job, you guys. Last question is option number 4. The nurse is assessing a client with a left-sided heart failure. Which of the following findings would be consistent with the condition? Is it ascites, pedal edema, persistent dry cough, right upper quadrant pain, or crackles auscultated in the lungs? Select all that apply. So there can be more than one correct answer here. And again, like I said, that webinar on September 22nd also covers select all that apply strategy before we move into the cardio topics. So if you get tripped up by these SATA questions, they can be tricky. Sometimes they feel overwhelming. We have a lot of really great strategy for that. So regardless of what the subject matter is, it's always good to go in through the lens of exam strategy. How many options should I expect? We always say it's between 2 to 4 on a SATA. Very rare you get an only 1 correct or an all 5 correct. And we have a couple other different tips and tricks to kind of reason your way through those SATA questions that maybe you're not confident in all of the answer choices, which, let's be honest, you're not going to be 100% confident on every single NCLEX question that you get. Alrighty, drop those answers in the chat. Let's see what you all are thinking. How can we register for the webinar? We have been putting the link throughout the chat, so make sure you look there. It says, here's the link for the 9/22 webinar, and then provides a bit.ly link. So you can scroll back in the chat. We'll drop it in another time before we leave, but we've done it a couple of times here. So just make sure you go back through that chat and find that link because we would love to see you there. Alrighty, so most of you guys got this. Correct options were 3 and 5. Way to go, you guys. That persistent dry cough and the crackles auscultated in the lungs. Remember, left side heart failure equals lungs. L equals L. So we're going to see the backup in our lungs, like that dry cough and the crackles. We're going to auscultate in the lungs because of that fluid buildup. Ascites and pedal edema would be right-sided heart failure. That's more like venous congestion. And right upper quadrant pain isn't necessarily indicative of either type, right or left, heart failure. So again, 3 and 5 were our correct options. Way to go, you guys. Lastly, we're going to jump to our QBank slide. Here is a look into our QBank for all of our users already purchasing UWorld and using UWorld. Here's how you can get more cardiac questions that target specifically what we talked about today, so you can improve on it if you want to challenge yourself. And for anyone who has not purchased UWorld, here's a look into our QBank so you can see just one of the many, many ways you're able to filter our questions to focus and work on exactly what you want to improve. So great job, you guys. Way to go. With that being said, thank you so much for staying tuned in. I hope this was helpful. Heart failure involves a lot of underlying patho, hence why we had to go through the full heart or blood flow in the heart. There are a host of things like blood flow, oxygenation, and circulatory concepts that you really need to understand before heart failure is going to start to make sense. But you guys did great. You handled some really tricky stuff and did a phenomenal job. So way to go. Again, all of these lives are on demand after we're done. So if you joined late, if you had to jump in and out, no worries. You're able to join, go back and rewatch it on any of our social channels. Again, YouTube, I think, is the easiest to search. So thank you so much for joining, and I will see you guys tomorrow. Bye-bye.